Hey guys, welcome back to my channel. This is Dr. Prasanjit Das, currently JR1 in the Department of Pharmacology, AIMS Kalyani, and today I am back with one of my seminars again. So without wasting any time further, let's get into today's video. So in today's video, I'm going to discuss about therapeutic drug monitoring. So therapeutic drug monitoring, I will be discussing this under the following headings, that is the definitions and introduction related to therapeutic drug monitoring, then criteria for doing therapeutic drug monitoring, indications for doing therapeutic drug monitoring, then the role of health professionals in therapeutic drug monitoring, sampling, assays, and factors affecting therapeutic drug monitoring, and the problems and the issues in therapeutic drug monitoring, and finally a related case report. So coming to the first slide, that is the definitions. So therapeutic drug monitoring involves analysis, assessment, and evaluation of circulating concentrations of drug in serum, plasma, blood, or other biological fluids. Okay, so it involves analysis, assessment, and evaluation of circulating concentration of the drugs in serum, plasma, blood, or other biological fluids. So mainly we are considering the serum and the plasma concentration. So it is the clinical practice of measuring specific drugs at designated intervals to maintain a constant concentration in a patient's bloodstream, that is thereby optimizing the individual dosage regimen. So it is helpful in optimizing the individual dosage regimen. So it is generally defined as the clinical laboratory measurement of a chemical parameter that with appropriate medical interpretation will directly influence the drug prescribing procedure. So therapeutic drug monitoring can be defined by all these three ways. Okay, so we can have three different definitions for the therapeutic drug monitoring, and all these definitions are considered true. So what is the purpose of doing therapeutic drug monitoring? It is to ensure the medication dose is within the therapeutic range, that is it should not cause any adverse effects to the individuals. So the process of TDM is predicated on the assumption that there is a definable relationship between the dose and the plasma or the blood concentration, and also between the concentration of the drug in the plasma or blood and its therapeutic effects. So dose should be correlating with the concentration, and concentration of the drug should be correlating with the therapeutic effects. Only then we can do the therapeutic drug monitoring of that particular drug. Now coming to the other definitions. So first is the therapeutic range. So therapeutic range basically represents a range of drug concentration within which the probability of the desired clinical response is relatively high and the probability of the unacceptable toxicity of the drug is relatively low. So we should get the desired clinical response, that is that there should be maximum probability for getting the desired clinical response, and there should be minimum probability for getting the unacceptable toxicity. As you can see in this image, therapeutic range, that is therapeutic response can be expected in this range. Okay, this is the range, that is therapeutic range, and above this there is increase in the toxicity, and below this it is subtherapeutic, that is the effect will not be produced. So this is what we call as therapeutic range, and here you can see the plasma concentration of the drug. Now coming to therapeutic window. So therapeutic window basically refers to both the concentration and the doses, rather than only referring to the blood concentration of drug as in case of therapeutic range. So in therapeutic range, we are just concentrating only on the blood concentration, but in case of therapeutic window, we will concentrate on the blood concentrations of the drug and also the dose of the drug. So therapeutic window is quantified as therapeutic index. So what is therapeutic index? So therapeutic index is basically considered as TD50 by ED50, that is toxic dose 50 by effective dose 50. So what is this TD50 and ED50? So TD50 stands for median toxic dose of a drug, and ED50 is median effective dose of the drug. So what is this median toxic dose of a drug and median effective dose of a drug? So median toxic dose is the dose of the drug that produces the toxic effect in 50% of the population, whereas the median effective dose is the dose of a drug that produces the therapeutic effect in 50% of the population. So in both the cases we are having 50% of the population, but in one it is producing the toxic effect, whereas in the other one it is producing the therapeutic effect. So in the graph which is present below, you can see this dose is ED50 because it is producing the dose in only 50% of the population, and as soon as we keep on increasing the dose, it reaches TD50, that is the dose at which we can see the toxic effect, that is in 50% of the individuals. So this is TD50 by ED50, that is therapeutic index, which is actually the measurable quantity relating to therapeutic window. Now coming to the goals of therapeutic drug monitoring, so it is to basically enhance the clinical outcome, as we have already mentioned. It is to decrease the toxic effects, it is to individualize the dosing regimens, because different individuals are having different pharmacokinetic and different pharmacodynamic parameters, and it is also used to detect poor compliance, because we will be able to monitor the concentration of the drug in the body fluids, mainly the serum and the plasma concentration. So the different indications for requesting plasma drug concentration includes, first is monitoring compliance, as we have already mentioned here in the goals. Then we have individualizing therapy, that is it can be done in the early stages of the therapy, and when we are changing the dose of a particular drug, that time also we can do the individualization of the therapy. Next is for diagnosing under treatment, because if the concentration of the drug in the plasma is less, then the effect will be less, as we have assumed in case of therapeutic drug monitoring. Next is to avoid the toxicity. Next, to monitor and detect drug interaction. Suppose we are giving some drugs which can interact with the drug which we are monitoring, and as a result they can either increase the effect of the drug or decrease the effect of the drug. Next is it will also help us in guiding the withdrawal of a therapy, like when we have to stop a particular therapy. So these are the indications for requesting the plasma drug concentration of the drugs for which we can actually do the therapeutic drug monitoring also. Now coming to the criteria for TDM, so first it is done for the drugs with narrow therapeutic range. Under this we have several drugs like phenytoin, we have carbamazepine, digoxin, theophylline, then gentamicin. So out of this, phenytoin and carbamazepine both are used as anti-epileptic drug. Digoxin is used. So in digoxin therapeutic range, it lies between 0.5 to 1.4 nanogram per ml, and above 1.4 nanogram per ml it is the toxic level. So here you can see the different toxic levels for and the different therapeutic range of the different drugs. So basically these are the narrow therapeutic range drugs. For this we can do the therapeutic drug monitoring. Then coming to the next one, therapeutic drug monitoring is done in the cases where there is a direct relationship which exists between the drug levels in the plasma and the pharmacological or the toxic effect. As I have already mentioned, the concentration will be relating to the effect of the drug. So the criteria that a drug should satisfy for the plasma concentration measurements to be useful, means it should be to be useful for the treatment process, is that first, there is difficulty in interpreting the clinical evidence of therapeutic or toxic effects. Means the drug which we are giving, it is going to produce a therapeutic effect or it is going to produce a toxic effect, but it is difficult to quantify that effect. In that case, we are going to look for the plasma concentration of the drug, because it will give us an idea of the amount of effect it can produce. Next, there is a good relationship between the plasma drug concentration and the therapeutic or the toxic, just the thing which I have mentioned earlier. Plus, the dose does not metabolize to important active metabolites, because if the drug is getting metabolized to important active metabolites, then the effect which we are correlating only with the concentration of the drug is not the one which is going to produce the effect, because we are having the active metabolites also, that they are also going to produce the effect. So in that case, we are not going to go for therapeutic drug monitoring, because it will be not that useful. Now, coming to the third criteria, that is the therapeutic effect cannot be readily assessed by clinical observation, as I've already mentioned. Example in cases of prophylaxis, very important, like lithium is used in preventing manic depressive attacks, and phenytoin is used in preventing fits after neurosurgery or trauma. So for seeing the prophylactic effect, we actually have a set concentration target, like we know that the particular concentration has to be achieved so as to provide the prophylactic effect. So this can be only observed with the help of therapeutic drug monitoring, in which we are monitoring the plasma concentration of the drug. Next is this therapeutic drug monitoring can be done when appropriate analytic techniques are available to determine the drug, and also to determine the metabolites also. So analytical techniques which are available should be useful to determine the drug concentration and the metabolite levels. So in that case also we can do the therapeutic drug monitoring. Now this is a flow chart in which we are actually reaching on making a particular dosage regimen with the help of therapeutic drug monitoring. First of all, we make the diagnosis of the disease, then a drug is selected which is going to be given to the patient, then the dosing schedule is designed to reach a target plasma concentration, and then we give the particular drug, that is in that particular dose, and then patient assessments are performed and drug concentrations are determined. So with this we can make a clinical judgment, and if we see that the effect is not appropriate or if it is more or less, then in that case we can do the dose adjustment whenever it is necessary. So with this we are actually individualizing the dosage regimen for an individual. So this is about one application of the therapeutic drug monitoring and how this entire process is being done. Now coming to the indications of therapeutic drug monitoring. So it is done for the drugs with narrow therapeutic range, as I have already mentioned the names. You can remember phenytoin, carbamazepine, that is anti-epileptic drugs. Then we have digoxin. Then we have antibiotics like gentamicin. Then we have lithium, which is used in bipolar disorder, and theophylline. For lithium, the normal levels lie somewhere between 0.5 to 1.5 milliequivalent per liter, and above 1.5 milliequivalent per liter we get the toxic effects, which are mainly CNS disturbances in the form of ataxia, tremors, lethargy, sedation, dysarthria, confusion, and even seizures. So these are the toxic effects, that is basically the CNS disturbances which are seen when the lithium levels in the plasma increases more than 1.5 milliequivalent per liter. Then coming to the next indication, that is when the signs of toxicity are not readily recognizable or indistinguishable from the disease process itself. Like, let us take an example for this. We know that digoxin is both the treatment and cause of cardiac supraventricular tachycardia. That is, in cardiac supraventricular tachycardia, the management is digoxin. But digoxin can itself also cause cardiac supraventricular tachycardia. So in that case, the drug plasma measurement will decide whether the arrhythmia, that is the cardiac supraventricular tachycardia, is either due to too little, that is too little of digoxin. This is, in this case, the cardiac supraventricular tachycardia is the disease pathology of the individual, or whether it is because of too much of digoxin, like because we are giving digoxin for some other disease, but if the digoxin concentration is very high, then it will also lead to cardiac supraventricular tachycardia. So for differentiating between them, what is going to help us is the plasma concentration of the particular drug. If it is very high, then we can understand that the cardiac supraventricular tachycardia is due to digoxin. If it is less, then we can understand that the cardiac supraventricular tachycardia is due to the pathology in the individual, and digoxin level has to be increased in that case. Next is, in case the clinical response is immeasurable in nature. So in that case also we will do therapeutic drug monitoring. For example, when there is no quick and reliable assessment of the particular effect. In case of lithium, which is used for manic depressive disorder, in this the outcome cannot be easily measured. So in this case we are going for therapeutic drug monitoring. Next, to diagnose and treat overdose, as I have already mentioned, lithium toxicity at plasma concentration more than 1.5 milliequivalent per liter. In that case we need to manage the toxicity. Then in case the individual are having concurrent diseases which are going to affect the pharmacokinetics of the drug, for example different renal, hepatic, or cardiac disease, because these will actually totally affect the pharmacokinetics of the drug, leading to adverse effects or even the therapeutic failure also. So in that case we need to know about the plasma concentration of the drug, and we have to monitor the dose accordingly. And for conditions like renal conditions, hepatic conditions, we actually calculate the dose taking into consideration all the renal and hepatic parameters also. Next, in case we are doubtful about the compliance of the patient, that is we are thinking whether the patient is taking the medicines properly or not, in that case also we can do the therapeutic drug monitoring to look for the concentration of the drug in plasma. So TDM is not useful in some of the conditions. As you can see here, it is unnecessary to employ TDM for majority of the medications. Like for majority of the medications, we don't have to do therapeutic drug monitoring. Therapeutic drug monitoring is mainly done in cases of the drugs with narrow therapeutic range, in case the drugs are with marked pharmacokinetic variability, and for medications for which the target concentrations are difficult to monitor, that is the concentration of the drug at the target site, and the drugs which are known to produce toxic effects and also therapeutic effects, that is known to cause variation in the adverse effects. So in such cases we are going to do therapeutic drug monitoring, and for majority of the cases we don't do therapeutic drug monitoring. So examples include when the therapeutic endpoints are easily measurable, that is it can be at a clinical or biochemical parameters. For example, blood pressure, we can easily measure blood pressure, so we don't have to do any therapeutic drug monitoring for antihypertensives because their effect can be easily measured. Then temperature can be easily noted down. So for antibiotics we don't have to do therapeutic drug monitoring. Next is blood sugar, we can easily measure blood sugar. So for oral hypoglycemic agents we don't have to do therapeutic drug monitoring. Then next is prothrombin time, that is the case of oral anticoagulants. So for that also we don't have to do any therapeutic drug monitoring. So in this case, the therapeutic endpoints are very clear and we can easily measure them. So in this case, we will not do any therapeutic drug monitoring. Next, therapeutic drug monitoring is also not done in case when the plasma concentration of the drug does not correlate with the therapeutic effect. As I have mentioned in the first slide itself, the concentration should be correlating with the effect. Just in case the concentration is not correlating with the effect, then in that case therapeutic drug monitoring cannot be done. For example, the drugs which act irreversibly and their effects persist long after the drug has left the plasma. It means the drug has left the plasma but still the effect is present. So this can be seen in case of hit and run drugs. So examples include COX inhibitor, that is aspirin, then we have anticholinesterase, then we have monoamine oxidase inhibitors which are used in case of Parkinson's disease. Then next is if there is a variation of the plasma protein binding of the drug. Example like basic drugs, that is disopyramide, bind to acute phase proteins. In that case, the concentration of the drug, which that is a free concentration, is not the one which will actually provide the effect continuously, because these drugs can dissociate from the plasma protein also later on. So we cannot actually quantify the concentration and actually we cannot relate it to the effect of the drug. So in that case also TDM is not that useful. Then coming to the role of health professionals in therapeutic drug monitoring. So first we need to know the different healthcare workers who are actually responsible for doing the therapeutic drug monitoring, and actually they play a major role in therapeutic drug monitoring. First is we have the clinical individual, that is the clinician, then we have the clinical pharmacist, then we have the clinical chemist, and then we have the nurses. So clinician will prescribe an appropriate drug and they will provide the initial dosage regimen and they will monitor the response. Then clinical pharmacist provides a plan for doing the therapeutic drug monitoring and interprets the result and designs a new regimen on the individual basis once the results are obtained. Okay, then the nurses are responsible for guiding the sampling procedure and to send the sample to the laboratories where the TDM is being done. Clinical chemist verifies the sample and performs the drug analysis and finally gives the report to clinical pharmacist, who is going to design the regimen based on the different individual parameters. So this is the cycle and the flow chart of the healthcare professionals who are involved in doing the therapeutic drug monitoring safely and in a smooth manner. Now coming to the different methodologies. So analytical methodology employed should ideally distinguish between the compounds of similar structure, that is unchanged drug and metabolites. That is metabolites should be differentiated from the unchanged drugs. Then it should be simple enough to be done as a routine assay and it should be unaffected by other administered drugs, with the drugs which are given simultaneously along with the drug for which we are doing the therapeutic drug monitoring. So these are the things which the analytical methodology should be able to pick up. Then coming to the sample collection, so we can take different samples. We can take venous blood, we can take saliva, we can take urine, we can take samples of hair and sweat, we can take bile sample also. Out of this, venous blood is the most commonly used sample because it is easily available. In saliva, we can do the concentrations of the drugs like phenytoin, lithium, digoxin. Then urine, it is used in case of anticonvulsants and psychoactive drugs. Then hair and sweat is used in case of forensic medicine for detection of the drugs of abuse also. Then bile to look for the presence of the drugs like penicillin, cephalosporins and aminoglycosides. So these are the different types of samples which we can use for doing therapeutic drug monitoring. Now coming to the proper sampling time. So the standard rule is that samples are collected once the drug concentrations achieve steady state. That is, steady state concentration is achieved after the 5 half-lives of the drug. But we can actually take the samples of the body fluids, that is the plasma, just in case if we are suspecting toxicity. Then in that case we can immediately take the samples for doing the therapeutic drug monitoring. In that case we don't have to wait for 5 half-lives or at a particular time. So other best sampling time will be basically the trough phase or the pre-dose phase, because at that point we are going to have the lowest possible concentration of the drug in the plasma. And suppose if we are getting the lowest possible concentration and if we are getting the effect also that time, so it means throughout the rest of the time when it is not in the trough phase, the drug will be producing the effect. So that's the reason why we take the trough phase plasma sample, that is just before the next dose. Now here you can see the steady state. So this graph is actually representing intermittent IV bolus regimen. That is the reason why you can see this is the first half-life, this is the second half-life, this is the third half-life, fourth half-life, fifth half-life. Okay, by fifth half-life, it reaches the steady state concentration and it is the trough phase. So this is the best time to do the sampling for that particular drug. And why I have mentioned that this is an intermittent IV bolus regimen, this is because as you can see here, first the concentration increases, and then when you give the next bolus, then again there is increase in the concentration. As you can see here, the concentration is supposed to be like X. Okay, so by this time, by this one half life, it becomes X by 2, and again that increases after giving the intermittent IV bolus, then again it dips down, then again an intermittent IV bolus, then again increases, then dips down. So it is like that, and once it reaches a steady state, then the increase is not further, the increase is there, but it is not going to have that particular pattern which it was having in the earlier phase, that is before reaching the fifth half life. Now coming to the different sampling time for different drugs, like the most common thing is once it is reaching the steady state concentration, in case of toxicity we can do it at any time, that is directly we are going to do the sampling once we are suspecting the toxicity. So we are having different drugs for which we have actually planned out different timings for which we can do the sampling. For example, in case of phenytoin, timing of concentration monitoring is not critical, that is we can do it at any time. Then in case of carbamazepine, it is having a long T half, that is 48 hours, so tough concentration is ideal here. Then in case of digoxin, measurement is made 6 hours after the last dose or just before the next dose. Okay, next is in case of theophylline, when it is given by IV infusion, the sample is to be taken after 4 to 6 hours of infusion, and infusion should be stopped for 15 minutes before taking the sample. So this is the requirement in case of theophylline. Then in case of lithium, it is very important, that is 12-hour sample is the most precise guide to dosage adjustment. So this we have to remember, because the therapeutic drug monitoring of lithium is done very commonly, that is 12-hour sample is taken. Next, coming to the practical issues in therapeutic drug monitoring, that is drugs with long half-lives should be monitored before the steady state is achieved. This is to ensure that individuals with impaired metabolism or renal excretion are not at risk of developing toxicity at the initial dosage regimen prescribed, as it can occur in case of drugs like amiodarone. So we need to monitor the drugs if it is having a longer half-life. Next is blood or plasma concentration changes throughout a dosage interval, and the time at which we are collecting the blood sample relative to the time of dose administration should be known so as to enable a sensible interpretation of the concentrations. That is, we need to know the difference between the time at which the blood was taken, that is the sample was taken, and when the last dose was being given to the patient. Now next is the analytical issues in therapeutic drug monitoring. Attention must be paid to timing of the blood sampling, as I have already mentioned. Then the type of blood sample also. Type of blood sample is also important, the measurement technique which is used, and the different interpretation of the results. The error in timing of sampling is likely responsible for causing the greatest number of errors. Okay, so the error in sampling time, that is error in sampling timing, is the one which is responsible for producing the greatest number of errors in therapeutic drug monitoring. For most of the drugs, the blood sample is to be withdrawn and it is to be kept in this heparinized tubes are used for storing the sample for therapeutic drug monitoring for most of the drugs. But for drugs like lithium and aminoglycosides, the blood samples should be allowed to clot and should be separated within 1 hour. Okay, it has to be clotted and it has to be separated within 1 hour in case of drugs like lithium and aminoglycoside. So this is an important point, lithium and aminoglycoside. Now continuing with the analytical issues in TDM, the laboratory must ensure that the assay which is used is reliable and specific, because if it is non-specific, then it can actually detect other molecules also, and that will give us the error in the results. Then method validation has to be done. Currently, majority of the drug assays which are performed are some variant of the commercially available immunobinding assay procedures. Immunobinding assay procedures, that is immunoassays. So the most commonly used procedures are fluorescence polarization immunoassay, that is a PIA. Then we have enzyme immunoassay, and then we have enzyme linked immunosorbent assay. So these assays are specific, but in certain cases metabolites or other drug like substances are also recognized, resulting in either a falsely elevated or decreased assay drug concentration reading. Okay, so it can either increase the concentration reading or it can decrease the concentration reading also. Now coming to the different assay methods, we are having spectrophotometry and fluorimetry. So the level of sensitivity is not too high for this method, and here the range at which we detect the drug is microgram per ml, and it is most commonly used for methotrexate. Next is thin layer chromatography, which is used in toxicology laboratory, and it is used for antidepressant drugs mainly. Then we have high performance liquid chromatography and gas liquid chromatography. It is highly specific, precise, sensitive, and multiple analysis can be done by this. Then next is radioimmunoassay. It is also sensitive and it is reasonably precise, but it requires the use of radionuclides, which is actually a disadvantage of radioimmunoassay. Next is enzyme immunoassays we also done, but still in this also there is a chance of cross reactivity. Then we can also do chemiluminescence. Now coming to the interpretation of the assay. So sample information which are required for acute interpretation includes the following. First is the time of sample in relation to the last dose. Next is the dosage regimen, that is the dose, duration, and route of administration of the drug. The age and gender of other drug therapy, that is the co-administered drugs, need to be known. The relevant disease status of the individual has to be known. Then the reason for request, that is the reason for request of doing the therapeutic drug monitoring should be also known. Example, it can be lack of effect, or it can be just a routine monitoring of the drug effect, or it can be in case of suspected drug toxicity. Coming to the factors which are affecting the interpretation of the assays, first is the protein binding in the plasma. Then we have presence of the active metabolites of the drugs, which are going to lead to errors and it will actually give us the false results. Next is variant pharmacokinetic properties, variant pharmacodynamic properties, the dose of the drug, sampling time in respect to the last dose of the drug, then the testing methodology, the different methods which are used for testing, and finally the genetic polymorphism, because it is also going to affect the pharmacokinetics of the drug. Coming to the potential problems in use of TDM, so in several cases, because of the lack of information, the TDM reports are not that useful because we don't know the details of the patient. Next is the accuracy of the drug assays can be varying. Then altered plasma protein binding, as I have already mentioned, presence of active metabolites, and if the blood collection is also not done properly, that is errors in blood collection procedures. So all this can lead to difficulties in TDM and lead to errors in therapeutic drug monitoring reports. Finally, coming to our experience, that is the case report. So a 45-year-old gentleman with bipolar affective disorder was given lithium for 3 months with no improvement of symptoms, and concentration of lithium was found to be 0 milliequivalent per liter in the plasma. So after a thorough inquiry, it was found that the patient used to spit the drug when no one noticed it. So here therapeutic drug monitoring has helped us to find out regarding the compliance of the patient. That is, all of the relatives of the patient were thinking that the patient is continuously taking the drug, but he is not getting the effect of the drug, but there is no improvement in the patient's condition. But this patient used to spit the drugs only after some time, like when no one notices it, he spits the drug. So this is the reason why this patient's lithium concentration in plasma was 0 milliequivalent per liter. So this is an interesting case where therapeutic drug monitoring has helped us to find out the compliance of the patient. That is, here the patient was totally non-compliant and the relatives were not knowing that he used to spit the drug after some time. So this is one advantage of using therapeutic drug monitoring, and it has occurred in our institution also. So this is our experience. So this was about therapeutic drug monitoring, and you can see these are the references which I have followed. With this, I would like to end this seminar. So I hope you like this video. If you like my content, please do like, share, subscribe, comment, and also press the bell icon so as to get notified whenever I upload a new video. Thank you guys.